Hello, everyone. We are live on our NCLEX RN review. And for the newcomers, we are currently on the 17th day of our 90-day free NCLEX review series. And we engage into various nursing topics, offering rationales for 2000 NCLEX questions. So make sure that you tell your friends who are preparing for the NCLEX about our free review classes, and subscribe and turn on notifications to stay updated with our latest content. For more information, please refer to the description box below, and we appreciate your feedback. So don't hesitate to share your thoughts or questions in the comments section for further clarification on any topics discussed. Now we'll go into another slide right here, and I'm actually going to promote into the course that we are offering. We are offering the NCLEX review program at our website at www.stancoastnclexcoaching.com. And we are offering engaging lectures and a wealth of over 3,000 NCLEX style questions to help you prepare thoroughly. And for quick review, we provide an audiobook and a concise bullet book to streamline your study sessions. And so you can enjoy our 10-hour animated video course and take advantage of 100 hours of preparation time. So you can also access our on-demand video library and practice with mock exams to boost your confidence that you can avail or you can access for about 6 months. And this will include about 2,000 NGN questions, and you'll have everything you need to succeed. So you can do this study on your own schedule, wherever you are. And so make sure that you are going to utilize Stancoast NCLEX coaching, and we're going to have to support your NCLEX preparation journey. Now, we will be talking about the respiratory or the acute respiratory failure today. And so here we go. So this is a condition that is very critical, wherein the lungs cannot provide enough oxygen to the blood or to remove enough carbon dioxide from it. Now, this can result from the low oxygen levels, let's say the partial pressure of oxygen that is less than 60 mmHg, or could be from high carbon dioxide levels with a partial pressure of CO2 greater than 50 mmHg, or this could have both, all right? So both elevation of the CO2 and a reduction in the oxygen level. Now, the description highlights that acute respiratory failure can also occur due to so many factors. Now, here we have the different factors mentioning here. First, the central nervous system factors. And this is going to be caused by at least, let's say, a drug overdose, or could be stroke or trauma, or this can be caused by some neuromuscular disorders. And one of those is the myasthenia gravis, which is an autoimmune disorder that can cause muscle weakness, that includes the respiratory muscles, that can also lead to the inadequate ventilation. And another issue is the polio, which is a viral infection that can cause paralysis of the respiratory muscles, and this can result into respiratory insufficiency. Now, another neuromuscular disorder, the Guillain-Barré syndrome, which is another autoimmune disorder, this is actually going to cause some demyelination of the peripheral nerves that will lead into muscle weakness and the paralysis, and this will really affect the respiratory muscles. Now, mentioning also the ALS, or the amyotrophic lateral sclerosis, which is a progressive degeneration of the motor neurons in the brain and also the spinal cord. This can also lead to the muscle weakness and respiratory failure. Not to forget about the upper airway problems, wherein could include stenosis. This can lead into acute respiratory failure as well, and this will typically involve narrowing of the trachea, or could be the larynx. Now, there's also going to be probably some spasms or paralysis. And when we're talking about the thorax and pleural conditions, we're going to mention about the scoliosis, which is the severe curvature of the spine, and this can restrict the lung expansion, and the person here will have the reduction of the lung volume, and it will also impair their gas exchange. Now, another incidence here is the flail chest, which is probably caused by the multiple rib fractures that can also lead to the paradoxical chest movement, and this can also affect the normal breathing. Now, we also have a hemothorax here. Under this category, we're in it's again the accumulation of the blood in the pleural cavity, and this can compress the lungs and it will reduce the lung capacity and also the oxygenation. Now, here we're going to talk about another group of factors under the cardiovascular and blood problems. So, top here is the congestive heart failure, which is basically the impairment of the heart function. This can lead to fluid accumulation inside the lungs, or known as the pulmonary edema, and this can hinder the gas exchange. Now, we're also going to talk about the valve diseases, or the valvular diseases, wherein there is now a problem with the blood flow. It can lead to pulmonary hypertension and subsequently causing the right heart failure, and also could be the left-sided heart failure, and again will cause impairment of the oxygenation. Not to forget here, guys, that pulmonary embolism can also be one of those. Remember that these are caused by the blood clots in the pulmonary arteries that can obstruct the blood flow to the lungs, and this can lead to decreased oxygenation as well. Now, anemia is another one, which is a reduced oxygen carrying capacity of the blood, right? And with that, this can also impair oxygen delivery to the body tissues, including the lungs. Now, not to forget here, the lower airways and alveolar conditions. And top to that is asthma, which is an airway inflammation, and this can cause the bronchoconstriction, which can narrow the air passages, and this can lead to the air trapping and also impairment of the gas exchange. Now, don't you remember that we just talked about the COPD, wherein there is chronic inflammation and also narrowing of the airways, and there is a resulting destruction of the alveolar tissue, and this is going to reduce the lung function and also the gas exchange efficiency. Now, part of that is the pneumonia, which is basically caused by the infection and will lead into the inflammation. There will be consolidation and fluid accumulation in the alveoli, and this can also impair the oxygen uptake and the ventilation. Now, we talked about the ARDS yesterday, the acute respiratory distress syndrome, which is basically the severe lung inflammation and injury, and this can lead to an increasing permeability of the alveolar capillary membrane and will subsequently cause the pulmonary edema, and our person here will have severe impairment of gas exchange. Well, that was quite a long list of the contributing factors, and it simply means that we really need to thoroughly obtain the patient's medical history for you to understand the underlying conditions that can contribute to the current symptoms, because it definitely helps the medical provider in order for them to establish accurate diagnosis and also the risk assessment and also treatment planning and also the overall patient care. Now, this time, guys, we're going to talk about the clinical features, the clinical findings of the acute respiratory failure. Now, for those who just came into the room, welcome back. I hope that you're going to enjoy and stay with us up until the end of this session. Now, here are the different clinical features in the acute respiratory failure. And so it will present several, or let's say severe clinical features. Now, the first symptom that you'll likely notice is definitely the shortness of breath. That's the topmost symptom. And this is going to be very alarming, right? And sometimes it can be accompanied by a cough or maybe not, but that really depends on what's causing the failure in the first place. Now, as the condition worsens, the patient might find very difficult to speak in full sentences because of catching their breath becomes very increasingly difficult this time. And so they might start using accessory muscles in their neck and also their chest in order for them to help to breathe, which can be a clear sign that there is respiratory distress, right? Now, they're also going to have some rapid breathing, known as tachypnea, and also tachycardia, which are very common as they're going to compensate for the lack of oxygen in the body. And if the oxygen levels drop way too much, you might notice that the patient will manifest a blue tinge color in their skin. And particularly, this is noticeable in their lips or could be the fingertips. Now, again, this is the cyanosis, right? And not to forget here, guys, that confusion can also occur in these people. And this is caused by the extreme fatigue and also the high levels of the carbon dioxide, or let's say the depression of the central nervous system. That's why they get very confused and disoriented. And they become restless as well. Now, with all these combination of symptoms, this will often signal that there should be an immediate medical attention to be provided in order to address the underlying causes and to support their breathing. Now, we're going to talk this time about the different diagnostic tests. So, when the provider is diagnosing the acute respiratory failure, there will be several diagnostic tests that are very important in order for us to understand the severity and also the underlying causes. Now, to top the list here is the analysis of the arterial blood gas. The ABGs is very fundamental because it will directly measure the levels of the oxygen, the partial pressure of oxygen, the partial pressure of the carbon dioxide, and also the blood pH. And I am assuming right now that you are still, you can still remember those normal ranges with the different components of the arterial blood gases, right? PaO2, PCO2, the pH, those are the basic ones, including the sodium bicarbonate. Now, the ABGs will confirm the diagnosis, and this will also assess the severity of the respiratory failure. Now, for example, guys, the low oxygen levels can indicate some issues like there is, let's say, ventilation or perfusion mismatch, or there could be shunting or hypoventilation. And the high carbon dioxide levels usually result from the hypoventilation. Now, also, the arterial pH can also show us respiratory acidosis if the carbon dioxide levels are way too high. Now, in some instances wherein there is chronic case, the kidneys might compensate, making the acidosis less severe. Now, moving into another diagnostic test that we often see in our patients is the chest x-ray, right? Or it could be the CT scan of the chest. These are also going to help in visualizing the lungs and also the chest structure. And they're also going to reveal any of these abnormalities, maybe an infection, or could be fluid buildup, or maybe some structural issues that could be causing the respiratory failure. Now, the images that the X-ray or let's say the CT scan can also pinpoint the problems. Maybe the person may have some pneumonia or maybe pulmonary edema, or let's say conditions affecting the lung function. And most common is the pulmonary embolism, right? Now, another testing that you will expect, it's not really diagnostic, but will support the diagnosis of acute respiratory failure, which is the complete blood count and also the metabolic panel. Now, talking about the CBC here, or the complete blood count, and also the metabolic panel, these groups are actually going to provide us broader picture of the patient's overall health, as the CBC can show us any probably infections or maybe anemia in the patient, while the metabolic panel can show us any electrolyte imbalances and also impairment in the kidney function, which can also impact the respiratory status of the patient. Now, if in case there is involvement of the heart, then there's also going to be a need for us to check on the cardiac enzymes. Okay, if there's probably pulmonary edema, then we can get to that test as well. And of course, these are going to, all these testing that we had mentioned, or I had mentioned, this can indicate that definitely your patient is undergoing the severe respiratory distress, and we really need to get ahead in dealing with this problem as soon as possible. Now, for the treatment, we are going to target the main issue, all right? The shortness of breath, the respiratory distress. Make sure that we are doing this in a very rapid manner, making sure that we have everything, all the ducks in a row, okay? Now, when treating the acute respiratory failure, our primary goal is to address the root cause. And this might involve using the bronchodilators, which will actually going to open up the airways. Could be the steroids in order to reduce the inflammation in the airways, and possibly the use of antibiotics to fight an existing underlying condition. All right, so please pay attention into these three common pharmacological interventions that you might see in the treatment of the acute respiratory failure. Okay, you might see them implemented all together, or maybe not on every case, but more often you will see these three. Okay, now the oxygen therapy is one of the topmost interventions that we can provide for the patient because of course they are hypoxemic, right? However, though, the approach will kind of vary because it will depend on the type of the respiratory failure they might have. Okay, and so for an instance, if there is such a thing, or if they probably are in this category, hypoxemic respiratory failure, well, what are we going to do here? We are going to use minimal amount of oxygen. Okay, the key here is to use just enough oxygen in order for us to raise the blood oxygen levels without causing oxygen toxicity. Now, I really want you to recall that one. I want you to remember that, okay? Because the toxicity itself can lead to the production of the free radicals, which can really damage the tissues. So guys, you have to be really careful. When you are treating the patient, especially when you're providing the oxygen, you really need to identify what the patient is having, because they might have, let's say, COPD, and it's not favorable for them if you're going to administer high flow oxygen. We don't want to do that because that is going to cause them oxygen toxicity. All right. And so in a case of hypercapnic respiratory failure, okay, the issue here is that the patient is having high carbon dioxide levels, and this is caused by the hypoventilation, wherein their process of breathing is affected. They're not able to breathe in and out. So this is going to cause accumulation of the CO2 in their bloodstream. And so our focus in this type of problem is to improve the ventilation rather than just increasing the oxygen levels. So yeah, like what I have said, make sure that you figure out what the patient's medical history is. It could be that they have a COPD, or it could be a hypoventilation issue. Is it probably caused by some medication that caused some respiratory depression? So you really need to investigate this, okay? Or else you're going to harm the patient. And like I've said, it is very critical that you have to be cautious with the oxygen therapy in COPD patients. Again, when you are giving them way too much oxygen, this can actually worsen their condition. And the reason for that, it's because it can lead to ventilation perfusion mismatch. All right. So, with the excess oxygen that you're giving to the COPD patient, this can disrupt the balance of the ventilation and also the perfusion in the lungs. And another thing is that it can lead into the Haldane effect. So, what is this Haldane effect? This is caused by the high oxygen levels that is being received by the patient, right? And this can now reduce the blood's ability to carry the carbon dioxide and making it harder to expel it. Now, another reason why they're going to go into toxicity, it's because of the suppression of the hypoxemic drive, because simply the COPD patient here often will rely on the low oxygen levels in order for them to stimulate their breathing. And so if they're going to lose that, then they're going to stop breathing. Now, if there's also way too much oxygen, okay, if we're giving them way too much, let's say a patient that has COPD, probably we're giving them a non-rebreather mask or a simple mask at 15 liters or 10 liters, this can really suppress their drive to breathe, and this is going to cause them to stop breathing. There is going to be reduction of the breathing efforts and will further cause accumulation of the carbon dioxide in their system. All right, so I hope that you understood those concepts. Now this time, what we're going to do here is to determine the different methods of oxygen administration. So we're going to go back into a little bit of the fundamentals of nursing on how to properly navigate with the different modalities of oxygen types. And in order for us to dig deeper, what would be the appropriate oxygen modality for this particular patient. And so we're going to talk about the low flow oxygen delivery system. So what is the example here, or examples? So we're going to talk about the nasal cannula here. So which is very common, right? The simple nasal cannula. So think of this as the little prongs that they're going to fit into your nostrils that will give you oxygen either in a low or the high flow. All right. So with the nasal cannula, the person or the patient that has the respiratory failure, initially when you're giving this type of delivery system, they really need to breathe through their nose in order for them to have the benefit of this nasal cannula. However, probably they're not really gonna get the benefit here, especially if they're hypoventilating, or maybe the cost of the underlying issue is really that severe. So probably the nasal cannula will not really work for them. And so the limitation with the use of the nasal cannula is that it can't really give you the oxygen levels much higher than 40%, as we're only going to be allowed to give it at 1 liter or up to 6 liters per minute. And it has that fraction of inspired air that is only up to 40%. Okay, so that is our FiO2. That is the percentage of how much oxygen that can be received by the patient. All right, so again, the FiO2 is only up to 40%, and we are allowed to give it at 1 to 6 liters per minute. Now guys, please remember that when you are delivering or when you're administering the oxygen, especially when you're going to start let's say 4 liters, you got to be careful in order for this patient to prevent having some nasal dryness or dryness in their mucous membranes in the upper respiratory tract. You got to be mindful, guys. You have to humidify their oxygen container. Okay, do not just leave it as a plain oxygen delivery. Make sure that you humidify that. You can use the still water and still that container. Make sure that it's going to allow proper humidification before the oxygen gets into their upper respiratory tract. This is very important, especially if your patient will need the oxygenation for quite a long time. Okay, question from Virtuous Lady. What is FiO2? Well, I've said that is the fraction, the percentage of the oxygen that a person can receive. Okay, so we're talking about, let's say 25, 30%, 40%, or 100%. Okay, so with the nasal cannula, it is only limited to 40% because of its nature. It's only delivered through the natural, ordinary nasal prongs. It can allow maybe some escape of the oxygen because of the short prong. And so it's not expected to deliver 100%, as we are talking about the regular nasal oxygen cannula. Okay, again, that is the fraction of the inspired oxygen, FiO2. Now, again, the advantage here, it's that the patient can easily use it. They can proceed with doing their business. They can still eat, or they can still drink water while they're wearing the oxygen nasal cannula. And we are still talking about the low flow, okay? There's just a very simple nasal cannula, because there is a different variety as we go along here. And so, again, easy to use. They can still eat, they can still drink whatever they want. They can go to the bathroom, of course, with a lengthened oxygen tubing. They can do that. All right. Now, talking about the next delivery system here, the simple mask, which is also considered as a low flow delivery method. So what is this simple mask? This is actually going to allow the mask to cover the patient's nose, the mouth, and it will deliver a moderate flow of oxygen. And looking into the flow rate, we can deliver with a range of 5 to 10 liters of oxygen per minute. Please pay attention here. We will start administering the simple mask delivery system with 5 liters, and the maximum is 10 liters per minute. All right. Now, this is going to give the patient about a fraction of 40% up until 60%. All right, please pay attention. 40 to 60%, and this is our expected FiO2 when we are giving this simple mask, and it will actually gonna give a much higher flow rate, okay, for this patient. And we are still talking about low flow. All right. Now, again, you got to be careful when you are delivering this kind of method, because our patient that has COPD would not really benefit this kind of delivery system. Okay. Simple mask, 40 to 60%. This can give them some oxygen toxicity. All right. So you really need to pay attention. Now, when we are going to deliver a different system here, we're going to proceed with the high flow system. So what are those different methods? Well, top in the category here is the Venturi mask. So what is this Venturi mask? Not quite sure if you still remember this. It's gonna look just like this. There's that mask, and you have that elastic material that will be used in order to kind of secure the mask on the patient's face, covering the nose and the mouth. And you will also see this different size of, we call them the entrainment device. All right. Now, here in the Venturi mask delivery system, the flow rate can also vary, starting with 4 liters up until 10 liters of O2 per minute. All right. Now, the fraction of inspired oxygen here can be, it can go up until 40%. Now, please pay attention here, because the Venturi mask can deliver a much more precise FiO2 delivery, okay? It can probably um, give a precise 24%, or it could be 28%, or 31%, 35, 40%. And the reason for that is because the entrainment device, which I'll show you right now, it has the different labels here. You see here the FiO2 in the different entrainment. Okay. So the color codes are actually going to help us to see what the FiO2 is going to be in this particular device. Okay, so you got 40, there's 28, there's 31, 35, or 24. Okay, now this Venturi mask, like I've said, has the different color codes adapter, which is going to precisely control the amount of the room air mixed with the pure oxygen. Now, again, this is a type of delivery system that is indicated for the COPD patients. This is going to be the safest mode for them. All right. Now, with the various sizes here of these entrainment ports, the Venturi mask can deliver a very specific concentration of oxygen, like I have said. And this is going to safely deliver accurate and also a much more consistent oxygen delivery to the patient. All right. So our Venturi mask is our friend, especially when we are dealing with a COPD patient. All right. Now, what would be the requirements, especially if we are delivering the Venturi mask? Well, the total gas flow at your face will need to match, or let's say exceed, the peak inspiratory flow rate. So if it doesn't really match, then the room air will get sucked in through the side holes of the mask, and this can subsequently lower the oxygen concentration that the patient is supposed to get. Okay, now what is the mechanism why the Venturi mask is very helpful? The reason is that it can combine a set amount of oxygen with a high but adjustable airflow in order to keep the oxygen level steady, and the oxygen shoots through a small opening at a very high speed, and it can pull in and mix with the room air. So the question here is, in COPD, can we use nasal cannula? Yes, definitely we can. And we had mentioned this, I had mentioned this in the past as well, that we are going to provide them at least the lowest amount of oxygen, okay? The lowest amount, so it's safe for us to start with half or 1 or 2 liters per minute nasal cannula, okay? So yes, we can definitely start them with a low level of oxygen concentration. All right. And with the Venturi mask, back to our discussion here, the oxygen concentration, actually, the mask I'm talking about, can provide about 30 to about 50%. Okay. And what is the advantage again for using the Venturi mask? Well, the Venturi mask can also stop the patient from rebreathing the carbon dioxide, okay? As just like any excess gas and carbon dioxide that is being exhaled or pushed out through the opening of the mask. So you see here, there's that opening on either side, okay? So they will not rebreathe the carbon dioxide, all right? So that is the safety feature about the mask. Okay, aside from that, 2 holes on each side, there's also that varying different FiO2s. And this is something that you need to collaborate with the respiratory therapist. They are really good in determining and also make sure that you have to coordinate with them. Okay, don't just change it without consulting the respiratory therapist. So it's very important that you communicate with them, because this is going to be tracked as far as the patient's responses to the therapy. We want to make sure that we are on the same page with our respiratory therapist. All right. We just can't change it without communicating to them. Okay. Now, another delivery method is what we call as the non-rebreather mask, or the NRM. So what is this? Okay, so let me just enlarge this one right here. So the non-rebreather mask actually looks like that. It has that inflatable bag, all right, that can hold 100% of oxygen, and it has a one-way valve that will stop exhaled air from getting into the bag. All right, again, the non-rebreather mask can hold 100% of oxygen, and it contains a one-way valve that will prevent the exhaled air from getting into the bag, which is the reservoir. Okay. Now it also has ports. It has that one-way valve that covers one or both exhalation ports. And this is to stop the room air from getting into the mask when the patient inhales. So with that, let me reduce that right now. And so it will also include those flaps, or let's say spring-loaded valves, that will let the room air in if the oxygen source fails, or if the patient needs to exceed the available oxygen flow. Now for the non-rebreather mask, let me enlarge this one more time. So see these right here? There's that port on each side, and there's that valve right here in this section. Okay, see that one-way valve, and the purpose for that one-way valve is that it will let the room air in just in case if the oxygen source fails, or if there's the need to, or the patient needs exceed the available oxygen flow. All right, so look at those flaps right here on either side, those like whitish colored round, or let's say circle shaped areas on each side. So this is really going to help in the delivery of the oxygen. Now let's talk about the flow rate. So you can deliver the non-rebreather mask. Yeah, someone said about the non-rebreather mask as very inconvenient. Yes, most of the patients dislike the use of any type of mask. Anyone can feel that it's claustrophobic, especially with a bigger size, looking into the inflatable bag. That's somewhat scary. If I am the patient, I have never worn one, and I don't want to. When I look into just the mask itself and the reservoir bag, I don't want it. But this is really going to benefit the patient, of course, except for those COPD, right? We really don't want to use this for those COPD patients, as this can really cause some toxicity. And so the non-rebreather mask is expected to deliver an FiO2 of about 70% up to 90%. Okay, so it will deliver that high concentration of oxygen. Okay, so this is what I always call as the rescue oxygen delivery system, especially if the patient might have some issues with hypoxemia. Maybe they had adverse effect from the narcotic analgesic, or maybe they're getting way too much of the sedative. And so in order for us to allow the patient to get that high delivery oxygen, we're going to have to provide this one if the simple mask doesn't work. Okay. Now, for the advantages, we're talking about how this can benefit the patient. Well, this is really going to allow the patient to achieve that high fractionated air at lower rates. Like I've said, it can be delivered at different levels and up to the maximum of 15%. So you can start it like around 10 liters per minute up until 15 liters per minute. Okay. So in some books it said 100%, but I would just safely put like around 70 to 90%, or if you like 100%. Yeah, that's okay. Now we're going to talk about another delivery system that is under the category of high flow. So we are going to talk about the high flow nasal cannula with a HFNC. I really want you to pay close attention here, guys, because you might get confused if you are not really familiar with this one. And so the high flow nasal cannula is under this category for the following reasons. Well, it can deliver up to 60%, and in some cases, it can also deliver up to 70 liters of oxygen per minute. Imagine that. That is pretty high, right? 70% or 70 liters per minute. And if we are talking about the FiO2, the high flow nasal cannula can deliver up to 100%. So let's get into the picture right here so you can see what it actually looks like. So since you are going to deliver this oxygen in a high level, I mean the concentration, this can really cause drying of the nostrils and also the upper airways, and it can really cause some dryness and also some bleeding, breakdown in the integrity of the upper respiratory mucous membranes. We don't want that. And in order to safeguard the patient from the adverse effect of the high flow nasal cannula, we are going to deliver it with a humidification system, okay? And so when we are delivering it, there should be this setup right here. We have to make sure that the oxygen is warmed, it's humidified, in order that the patient can tolerate this delivery method. And look at that tubing here. This is way different from the regular nasal cannula, right? Like the simple nasal cannula. This is going to be a lot thicker with the tubing itself. Just by looking at it, way, way different, okay? And again, our delivery system here is much more sophisticated. You gotta humidify the oxygen delivery, okay? So the mechanism here is really to warm the air before it enters the patient's respiratory tract to prevent dryness of the mucous membrane, okay? And this is going to be regulated as well on how much humidification that we're going to provide to the patient, okay? So the disadvantage in the delivery of the high flow nasal cannula is that, the advantage rather, okay? So with the high flow nasal cannula, this can ensure that the patient can get a consistent and also adequate supply of oxygen, which can really help manage their severe respiratory conditions more effectively, okay? And so with this type of delivery system, our patient can really get the benefit, especially if they really need that 100% O2. And also this will avoid the more invasive methods, let's say mechanical ventilation. If the patient's status is not that bad, as let's say they probably don't have this other underlying conditions. So this is really going to help out in avoiding the use of the mechanical ventilation system, okay? So again, 100% oxygen delivery system. Again, this is not going to be safe for your patient with a COPD, okay? Our safest bet here is the Venturi system, okay? In the previous page. Let me go back to that. So here is our friend, the Venturi mask, all right? Now let's move forward here with our topic. And so with the delivery system, we're also going to assume, just be ready, guys, if in case our patient will not respond to the different delivery systems, they're probably not responding to the high flow nasal cannula, or maybe not responding to the Venturi mask, then possibly the medical provider will order these two, either the CPAP or the BiPAP. So what are these two? Okay, so these are non-invasive type of positive pressure ventilation systems, and they are more suitable for alert patients. with, let's say, impending respiratory failure. Okay, again, the CPAP or BiPAP is much more suitable for those patients that are alert with impending respiratory failure. So if the patient cannot breathe independently, they need to be intubated. Okay, so in this section of our discussion, we are going to um, differentiate the two systems, okay, either the CPAP or the BiPAP. So as we are talking about the function here, okay, what's the difference? Well, the CPAP can deliver one constant level of the pressure, and this is for both inhaling and exhaling. Okay, again, for the CPAP, it can give continuous level of positive airway pressure in both phases of the respiration, when they are inhaling and exhalation. And this can be challenging for those patients that may have a COPD as well, because they don't really like that positive pressure when they are breathing out. It seems like the positive airway pressure can prevent them from exhaling effectively. So that is one disadvantage about the CPAP. However, though, with a BiPAP system, it will give, or it will provide two pressure levels. Higher pressure maybe when the patient is inhaling, and this is what we call as the IPAP, which stands for the inspiratory positive airway pressure. So again, the BiPAP will deliver two pressure levels. So when they're inhaling, we can set up high with the IPAP, and we can set a low pressure, and this is going to be provided when the patient is exhaling, and this is what we call as the EPAP. So this is the advantage for the administration of the BiPAP. All right, when they're breathing out, the patient doesn't really feel that external force that kind of like contradicts or challenges their exhalation. Now, as far as the pressure settings, that's pretty much it, right? Single continuous pressure setting, and while for the BiPAP, it can deliver two distinct pressure settings, all right? It can vary for the inspiration and also the expiration. Now, for the indication, what's the use for the CPAP? Well, the CPAP is intended for those patients that may have some obstructive sleep apnea, OSA, okay, obstructive sleep apnea, okay? So this is a very common device that a patient can use in their homes if they have diagnosis of the obstructive sleep apnea. The medical provider can order this device in order for them to use this when they're sleeping, maybe during the daytime, if they sleep during the daytime or the nighttime, okay? And for the BiPAP is indicated mostly for those patients that may have COPD, much more serious conditions, and for those conditions that might require different pressures that are needed to assist with their breathing, okay? Now for the mechanism, okay, so what would be that? The mechanism here will actually, with a CPAP, it will require much higher inspiratory rates in order to maintain the continuous pressure, whereas the BiPAP can do some alternation between the preset pressures in order for the patient to have a much easier breathing during the inhalation and exhalation. Okay, so this is really what sets them kind of like different from each other. Now, as far as like the comfort of the patient, the CPAP appears to be more uncomfortable. It's because of the continuous high pressure that it's going to exert on the patient, whereas the BiPAP is generally more comfortable because of the lower pressure during the exhalation. Okay, so this is the big thing about the use of the BiPAP. It exerts lower pressure during the exhalation. But guys, as far as like with my experience with different patients, including the COPD patients. Yeah, there are some success stories about the use of the BiPAP, CPAP, or let's say mainly about the CPAP. There are those patients that can really use them effectively. They have not developed that claustrophobia. Well, of course, they can use the CPAP at home very safely. But for some, they're going to end up removing it in the middle of their sleep. And so this is really kind of scary when they have the obstructive sleep apnea and they get this thing off their face. All right. But in the hospital settings, yeah, you also need to assess your patient, make sure that you monitor the patient once in a while, in a regular basis. You have to really pay attention because some of these patients are already confused. Most of them are elderly. They are not going to follow your instructions. So you have to be careful, make sure that you have at least somebody helping you, maybe a family member to stay with them, especially during confused states, in order that they can keep the mask on if they really need to have this type of delivery system. Okay. Like I have said, there's that enough number of patients that will not be able to tolerate because of the claustrophobia, either the BiPAP or the CPAP. Yeah, because of the use of that huge mask to cover their face. All right. Now, at this point, we're going to have to talk about the treatment of the acute respiratory failure. Well, lastly, if the patient will not respond to the oxygen delivery systems, or let's say the non-invasive positive airway pressure, then we don't have a choice. If they're going to agree into getting the mechanical ventilation system, then this would be our other route here, or other resort. Okay, so it is going to be very necessary for us to deliver the system as ordered, and for those patients that may have severe acute respiratory failure, when they cannot maintain adequate oxygenation or cannot do the ventilation on their own. Okay, so like I have said, in those different risk factors on the first slide, remember those so many risk factors? Yeah, those are way too much to remember. But again, when everything fails, when they cannot maintain that oxygenation on their own, or there is a failure of their respiratory muscles, then definitely the mechanical ventilation will at least help them. So if the lungs of the patient are severely compromised, or let's say their breathing muscles are very weak, or let's say fatigued to function effectively, then this is our option. So in this discussion, we are going to identify why the mechanical ventilator will really support the breathing. Well, one is that it can ensure a much adequate oxygenation to the patient. And how does it work? Well, the mechanical ventilation system will deliver a much precise concentration of the oxygen delivery into the lungs, and it also can ensure much efficient oxygen that can reach into their bloodstream, even when the patient's natural breathing is inadequate. Okay, that is why the mechanical ventilator is effective. Okay, again, it can deliver a much more sufficient oxygen to reach to the bloodstream, even when the patient's natural breathing is inadequate. Now, another benefit that the patient can get from the use of mechanical ventilation is that it can also expel carbon dioxide. It can prevent respiratory acidosis. So how does this thing work? It will provide a much more controlled and also efficient ventilation, and that the machine can also help to expel, again, the carbon dioxide from the lungs, and for those patients that cannot effectively do it on their own. Now, another is the reduction of the work of breathing in this patient. Well, the mechanical ventilator can actually take over the effort of breathing. It will decrease the physical workload on the respiratory muscles. And another benefit is that it can also decrease the overall metabolic demand on the body, which is going to be beneficial for those patients who are very critically ill and for those who are going to need to conserve their energy for healing and also the recovery. Okay, so don't forget about these three mechanisms why the patient really can benefit the use of the mechanical ventilator. Now, at this point, we're going to have to proceed with the different nursing interventions, different assessment actions and interventions. So, very important, guys, especially during the assessment phase, we definitely need to assess the patient for the symptoms that are related to the systemic effects of the acute respiratory failure. So, what are these symptoms? Well, that includes the hypoxia, the hypercapnia, wherein there is a build up of the carbon dioxide in the bloodstream, and also the acidosis. So those are the things that you need to assess for this patient. Another is the dyspnea, which is basically the perceived difficulty of breathing. And this is very important for you to really check because it is the hallmark of the respiratory failure. Okay, dyspnea is the hallmark of respiratory failure. You really need to see and check the patient if they feel like they're having a hard time breathing, especially if they're just doing their daily activities, maybe just watching TV or eating or maybe watching a book. And so if they are complaining about dyspnea, even if they are just sitting, not doing an activity that would cause them to exert much more effort, then this is a huge issue. Now, we are also going to assess the patient for any kind of chronic respiratory problems because, again, acute respiratory failure can be associated with all those other chronic stuff, right? And so even when there is small increase in the difficulty of breathing, this can already signal that there is a serious problem that with even how well the body is exchanging the gases. Now, along with that, we have to also assess for any changes in the respiratory rate and also the pattern in the breathing. And so how are we going to do this? We are going to listen to the lung sounds of the patient. Make sure you do that, guys. Always auscultate. You have to check the patient's oxygen saturation using that pulse oximetry. It can really help out in the delivery of a timely treatment for the patient. Now, you have to also check the patient's end-tidal carbon dioxide. Make sure you do this. You have to monitor. Why? Because in a patient with acute respiratory failure, this can really give us a valuable information about the adequacy of the ventilation and also the gas exchange. So make sure you have this information available. The end tidal CO2 in a patient. Again, it will give us information about how adequate the ventilation is and also the gas exchange. So if there is any change in the levels of the end tidal CO2, then it might indicate that there is, let's say, hypoventilation or very slow breathing or maybe hyperventilation, the exact opposite. So this is going to really guide us to adjusting the respiratory support that we need to give to the patient. Now, for the end tidal CO2, we are also going to, the device itself can also detect some complications, maybe complications such as a respiratory depression or a complication, an impending airway obstruction as well. So this is also going to allow us to promptly intervene in order to prevent the patient to develop into respiratory compromise and in order for us to improve the patient outcomes. So look into the different benefits of the end tidal CO2 monitoring. Again, it can reveal the current ventilation and gas exchange, and it will also determine the kind of alteration the patient have. Is it hypoventilation or is it hyperventilation? And lastly, it can also detect possible complications such as respiratory depression or, let's say, airway obstruction. Now, another part of our care in this patient is to review the arterial blood gas, or if there is no blood gas data that is available yet, well, you're going to have to collaborate with the respiratory therapist or maybe the phlebotomist, but most often it will be the respiratory therapist that will be doing the ABG. They're going to extract the blood, arterial blood gas, of course. And in some cases, it's the ICU nurse that will be extracting the arterial blood gas. Okay. So we have to really monitor the results and check and notify the medical provider if there are some imbalances in the values, let's say the pH, the partial pressure of the oxygen, the partial pressure of the carbon dioxide, and also the sodium bicarb level. Okay, so going into the ABGs itself, the results that we will be getting will provide us more immediate insights on how severe the underlying cause is about the respiratory failure. And the ABG result can also assist the healthcare provider in order for them to customize the plan, the interventions in order to improve the patient's oxygenation and also to optimize the patient's respiratory function. Now, we're also going to assess the patient for any symptoms of hypoxic respiratory failure. So what are these manifestations? Well, we are going to look out for those signs like restlessness, or maybe they are becoming so irritable or maybe confused, or it could be that they are going to be tachycardic. A rapid heartbeat can signify that there is going to be hypoxic respiratory failure. Okay, let me write those things. So one of those symptoms is restlessness. We are talking about hypoxic respiratory failure. So one is restlessness, and another, okay, is the irritability. And then lastly, we have more confusion and tachycardia. So these are just a few. Confusion and increase in the heart rate. Increase HR. Restlessness, irritability, rapid heart rate, and confusion. Those are symptoms of hypoxic respiratory failure. So definitely these are going to suggest that the body is not getting enough oxygen. Now at this point, we're going to have to assess the patient about hypercapnic failure. Okay, let me delete that because it's overcrowded. So the symptoms of hypercapnic failure will include the decreased level of consciousness. So let's say the patient was quite alert early or before, and then all of a sudden they are now getting drowsy, or maybe leaning towards being lethargic, or maybe changing into an obtundant level of consciousness, or it could be that they are probably just those variation, drowsiness, lethargy, obtundation, or it could be comatose in worst case scenario. And so with that hypercapnic failure, pay attention to their level of consciousness, guys. They might complain about the headache because of the buildup of the CO2 in their system, and they will become drowsy, they will become lethargic, and worse is that they're going to end up with seizure activity. And that is because of the lack of oxygen delivery into the brain tissues. That's why they're going to end up with a seizure activity. Now, also the patient will be assessed. You gotta pay attention here. Make sure that you're also looking for this possible signs of acidosis because of the buildup of CO2 in the bloodstream. Again, it will affect their level of consciousness, and with their heart rate, it will become irregular as well. Okay. Now, we're going to have to continue our nursing actions here with the different nursing interventions. So we are going to go back into the oxygen therapy. So you really have to assess your patient carefully. Look into the pulse oximetry reading, the ABGs. Those are the things that can really help you out. Okay. So the administration of oxygen really is very crucial in the treatment of acute respiratory failure. And our goal here is to maintain the partial pressure of oxygen above 60 mmHg. Okay, that is our goal, above 60 mmHg. Now, this is going to prevent the overall hypoxia experience and also prevent the multi-organ damage. Now, if the oxygen therapy is not able to maintain that, well, we're going to have to also anticipate the delivery of different medications. So one of those probably will be the delivery you have to administer, or maybe the respiratory therapist will have to administer the beta-2 adrenergic agonists. We are back to that. An example here is the albuterol, which is a very popular bronchodilator. Albuterol, this is a beta-2 adrenergic agonist. This is going to target those beta-2 receptors in the smooth muscles of the lungs, in the main bronchus, the bronchioles. So when the medication will target those receptors, the airways will now be much more relaxed. It will now allow the passageway of the gas exchange, okay, or the gases itself. When the patient needs to breathe in, they can get the oxygen that they need, and they can facilitate the exit of the used air as well. So you can deliver this medication either the nebulizer, or it could be with a meter dose inhaler. But most often when we are taking care of the patient in the acute phase, you're going to have to anticipate the delivery through the nebulizer. Okay. Now, the medication, again, please don't forget, the albuterol will cause dilation of the airways. That is the drug action. Bronchodilation. Airway opening. Bronchodilation. Okay. All right. Now let's move on into maybe another classification of medication, maybe other bronchodilators, or maybe with the use of the anti-inflammatory glucocorticoid. So I'm talking about the, here, let me erase that because it's getting way too crowded here. So maybe with the use of the ipratropium, which is going to be delivered together with the albuterol. This can also lead to the bronchodilation. That's the ipratropium, which is an anticholinergic medication. Right? Anticholinergic drug. Now, expect that during the acute phase of the acute respiratory failure, the medical provider might order the administration of the IV glucocorticoid, and in most instances, we're going to expect the delivery of methylprednisolone. Methylprednisolone, which is basically a steroid. Prednisolone. Or the brand name itself, Soliomedrol. Again, this is delivered IV in order to relieve the inflammation. It will reverse the effects of the inflammatory processes inside the lungs and the airways. This can really help out in the reduction of the inflammation. Okay, that is the significance about the anti-inflammatory medication. Okay, the glucocorticoid. I'm not going to go back into different adverse effects again because we have gone through this yesterday. Way too many adverse effects that you need to watch for as well. So with the glucocorticoid, expect that this might be ordered maybe every 8 hours with a corresponding amount of the medication in order to facilitate a constant level of the medication in their bloodstream. So this is something that you need to keep an eye out. Now, the administration of analgesics as well would be very important. Okay. Looks like we have Mandeep Kaur mentioning about the AIM. So I believe that she's talking about the AIM standing for the albuterol, ipratropium, and the methylprednisolone. Is that what you were talking about? Yeah, because that would really fit that one. AIM, the albuterol, ipratropium, and the methylprednisolone. I'm just trying to guess. But again, that would probably be what you're talking about. Okay, so analgesics here. What would be the role of the analgesics in the treatment of the acute respiratory failure? Well, we are also gonna treat if the patient has some pain issues. This can also help them in reducing their respiratory effort. And so, for example, if they might have some chest pain, right? Yeah. If they have some chest pain going on, maybe secondary to pleuritic chest pain, or could be MI with cardiogenic shock. Yeah. So we are going to treat that pain. Make sure that you specifically, you have to thoroughly assess the patient's level according to the pain, the severity, the characteristic, what is aggravating the pain, and also what is going to relieve that kind of pain. So make sure that you have to pay attention to those different assessments. Again, we are talking about the characteristic of the pain, the level according to the severity, the onset, the relieving factors, and the aggravating factors. Okay, so make sure that you have to ask the patient around this time. Make sure that we can really address this. Now, we're also going to talk about the different neuromuscular blockade drugs. Why? Well, if our patient is going to be placed on the ventilator, the mechanical ventilator, of course, this will require us to administer some of these medications. Let me erase that. It is expected that we'll be delivering this medication called the vicuronium, which is a non-depolarizing neuromuscular blocking agents. I would just call this as paralyzing agent. Okay, to simplify things. So paralyzing agent, which is basically gonna target the respiratory muscles in order that the mechanical ventilator system will be exerting much more effective result into our patient, especially because with this can the medication can allow the muscle relaxation. I'm talking about the respiratory muscles of the patient. So in order that the mechanical ventilation can do its job, because if the patient's respiratory muscles are still kind of contracted, then there will be poor compliance. The mechanical ventilator will not work. So think about paralyzing the patient's respiratory muscles in order that we can properly deliver the therapeutic effect of the mechanical ventilator. So this is the reason, guys. Okay, so the paralysis that we are giving to the patient is temporary. Okay, it's temporary. This is not going to be a permanent paralysis. And the intent for this, again, it will relax the respiratory muscles, nothing else. All right. But when you are going to be in the ICU, you really have to monitor the patient for what other adverse effects this medication can do, because there are some as well. We're going to have to talk a little bit more of that when we go into the pharmacology. Now, another is the use of the diuretic medication. So if in case there is, if the acute respiratory failure could be caused by the congestive heart failure, right? So there is now fluid overload in the vascular system. This can overwhelm the heart as well, and it can lead into pulmonary edema when there is a congestive heart failure. Pulmonary edema. All right. So I'm talking about, again, congestive heart failure. And if in case there is inadvertent administration of IV fluids, and it will aggravate it can worsen the congestive heart failure of the patient, and it can lead into pulmonary edema. Pulmonary edema is another critical situation that you need to address very promptly. You don't want to sit in this situation. The patient can possibly lead into respiratory arrest. If we're not going to deal with that, make sure that you make that critical phone call to the medical provider when you have after you had carefully assessed the patient. Okay, so what is a pulmonary edema basically? Well, this is now the congestion of the fluids in the lungs, in the pulmonary capillaries, maybe because of the backflow of the fluids coming from the left side of the heart, such as in the case of a left-sided heart failure, maybe because of the mitral valve prolapse that has been going on for quite a long time. So this can cause backup of the blood coming from the left side of the heart. It goes back into the pulmonary veins and eventually will lodge into the pulmonary capillaries. Now, guys, imagining when there is now congestion of blood in the pulmonary capillaries, it can also increase the hydrostatic pressure, right? So this can affect the permeability of the capillaries. It will now allow the liquids or the fluids to cross from the capillaries to go into the alveoli. That is why the patient will end up with crackles, okay? Air hunger, their oxygen levels will go down, and they might end up with that pink frothy sputum. So we're going to talk a little bit more about pulmonary edema in a separate session. So again, that is why the diuretic therapy, especially with the use of Lasix, which is the brand, right? I always use the brand, even though, yeah, we know that is the furosemide. So this is a rapid acting diuretic that can really help the patient in getting rid of the excess fluid in the lungs. That is the Lasix. Okay. Okay, welcome. We have A+. Welcome to the class. And so Lasix or furosemide, this is a loop diuretic, and I've mentioned this in our renal system concepts. And this is going to work instantaneously within 5 minutes. After you administer this medication intravenously, within 5 minutes, the patient's body will respond. It will now cause the expelling, or it will allow the patient to urinate, cause the shifting of the fluids from the lungs. It will now be excreted through the kidneys. Okay, so the patient will be diuresing really fast. So within a matter of 30 minutes, probably your patient will be putting out 2 liters in the urinary bag. Yes, and the patient's urinary output around this time would be very light. Okay, there is that diluted urine output that you will notice. So again, the furosemide will be very effective in treating the pulmonary edema, which can also treat the acute respiratory failure. And this is a very common experience, guys. Very common, especially in the elderly population in the med-surg floors. Pulmonary edema is a common thing because of possibly there was fluid overload from the treatments, IV. administration, or maybe there is a problem with the excretion. Maybe the patient has a pre-existing renal failure. They can't really get rid of those extra fluids. So they're going to end up building way too much fluid in their bodies, in their vascular system, and they're going to have that pulmonary edema. It will surprise you if you're not careful. So you really keep an eye, guys, on the intake and output. Now, too much for that. We're going to talk about the antibiotic therapy. Why? Well, the antibiotic therapy can also help the patient in the acute respiratory failure, especially if the contributory factor is maybe because of a bacterial infection, let's say pneumonia. So the anti-infective agents can really help the patient at this time. Now, part of the care here, guys, is to make sure that we nurses have to save the patient's energy. Okay? Be mindful of this one, guys. So what does that mean? Well, we have to cluster the patient care activities. This simply means that we are going to encourage minimal self-care. And so if they are very that exhausted in the midst of the acute respiratory failure, you're not gonna force the patient to go to the bathroom, walk steps to the bathroom if they're short of breath. No, of course not. When they are, let's say, diuresing because you gave them the Lasix, because you noted that their patient has pulmonary edema, and you got the order to deliver the furosemide IV. And so the patient will end up with diuresis, right? And so don't force them to use the bathroom or let's say walk, let's say 10 feet away from their bed. No, you gotta conserve the patient's energy at this point. You have to be very mindful of this. As far as delivering the care, you have to cluster it. Don't come back and forth, different procedures. This will really overwhelm your patient. This can cause them exhaustion. And so you have to cluster those care activities. All right? Do not overdo it. Now, another thing is that we're going to incorporate the breathing exercises, which can really improve their lung function, the respiratory muscle strength, and this can also help them in the recovery process, especially. Now, to recap all this, it's very important, guys, that you have to carefully assess your patient to what contribution, the different contributory factors that might have caused the acute respiratory failure. So make sure you do that. And when you are managing, when you are delivering the intervention, make sure that you are doing the assessment very thoroughly before you jump into the intervention. Make sure that you assess first in order that you can plan ahead of time to prioritize those high yield actions. Okay, let's say, for example, administering the oxygen therapy. This is really our main goal, to maintain at least 60% of the oxygen partial pressure in order to revert the hypoxemia. So that is one, that is priority. Okay, so you might be asked, what are the priority interventions in your patient with acute respiratory failure? Make sure you do that. Administer oxygen therapy, positioning, and the administration of the medication. So like I've said, these are your ingredients, your cocktail. Yes, I would call them the drug cocktail for acute respiratory failure. The beta-2 adrenergic agents, the bronchodilator, albuterol, the bronchodilator ipratropium, okay, which is going to help with the bronchospasm as well. The anti-inflammatory glucocorticoid, which can also decrease the rate of the inflammation, and possibly the use of analgesic medication in a patient that may experience chest pain. Okay, and then finally, when our patient is placed in a mechanical ventilation system, think about the use of the non-depolarizing medication like the vicuronium in order to facilitate a much more effective delivery of the mechanical ventilation system. Okay, and again, we have others to remember. Diuretic therapy if there is pulmonary edema, antibiotic therapy if our patient needs to be treated for the infection, like pneumonia. All right. So if you are going to address these important aspects comprehensively, you can really optimize the patient outcomes. And it's very satisfying, guys, when you are going to be the primary care nurse of this patient and you have delivered systematically all these nursing interventions that you have given to this patient. It is such a relief that within just a matter of a few minutes, you will see some changes, some improvements of your patient, especially. And so, yeah, it's quite satisfying, I tell you. I've had so many experiences wherein I encounter more of the pulmonary edema, and so you just gotta jump ahead and make sure that you deal with that situation right away in order that you can reverse the situation in order to prevent the much more severe complications. Um, and so, guys, I hope that you have gained more insights into this lecture, and I will see you again tomorrow. And we will be talking about the nursing management of the pleural effusion, the pleurisy. And so I will see you again in the next 24 hours. Thank you. And you have a great day. Take care, everyone. Bye bye.